Question 84, which of the following muscles is most likely contributing to this dysfunction? We've got a great OMM question for you here. A 19-year-old soccer player presents with right-sided groin pain and hip tightness after repeated sprint drills. On exam, the right ASIS is inferior to the left, the right PSIS is superior, and the standing flexion test is positive on the right. Innominate questions should be gimmies. They're very conceptual. All right, let's do some puppet hands with me. All right, do this puppet hand experiment with me if you're not confident with these innominate questions. Take your index finger and your thumb, and you're going to form a shape like this, where this is your thumb and this is your index finger. And you're going to do that on both hands. So if you're top down, you're looking at your hands, and it should look something like this. This is currently perpendicular with your line of sight. So now make this parallel. So take your hands, just turn them 90 degrees. So it looks like this. When you're looking at them, your index fingers are hidden behind your thumbs. This is how I want you to imagine the innominates are normally. Okay, so first things first, know what side the standing flexion test is positive on, because that's the side that is dysfunctional. They also kind of hinted at it with the right-sided groin and hip pain, but this is a right standing flexion test, so this is the prodigal son. Now we go to the specific findings. Right ASIS is inferior to the left. Let's go back to our cross-section, our top-down aerial view here. Make your index finger the ASIS and your thumbs the PSIS, and it's going to be like that on both sides. So we're going to do right ASIS is inferior to the left. So ASIS, that's your index finger. Take the index finger, your right hand, and the thumb, and then just rotate them forward. So you should end up with something like this, where this top line is your thumb, and this bottom line is your index finger. And then let's just confirm that the right PSIS is superior, right? If our thumb is the PSIS, then yes, it works out. So that makes sense with what they describe. Just doing that one motion moves both. So now we have to think, okay, what does this look like? Well, the problem is the right side. So whatever the right side is doing is the diagnosis. The right side is rotated forward, right? Or anteriorly. This is an anterior right innominate. Now we come back over here and think, which one of these muscles could cause an anterior right innominate? And now it's all about anatomy, knowing your origins and insertions, and knowing, if you were to shorten those muscles, what would the net effect be? What about biceps femoris? What would that look like? Well, if this is your knee and this is your pelvis, and this is anterior and this is posterior, I'm going to draw a stick between them. The biceps femoris is on the posterior side. It's part of your hamstring, and it's going to attach something like this. It's actually going to go all the way to the leg. It actually inserts right on the fibular head, so it goes past the joint. So if this muscle were to shorten, right, we had our tibia / fibular head here, and that's your foot. What would the net effect be if this green line shortened? The net effect would be something like this, right? Where now we're basically squatting. We flexed the knee. That is only if the foot does not move. If the foot moved, then you could get something like this. Still, you flex the knee no matter what. However, you're still upright. It depends on what's moving. If the foot is fixed in place, then you'll bend down and squat. If the pelvis is fixed in place, then you'll just pick your leg up. Is that going to cause an anterior dysfunction of the innominate? If our innominates are kind of looking like this, and this is inserting on the posterior side of the innominate, if anything, it's going to pull it posteriorly. So the biceps femoris is out. That would cause a posterior rotation. Glute med is on the side of the hip. It's lateral. This has nothing to do with anterior or posterior rotation of the innominate. So that one's out right away. Same thing with piriformis. Piriformis is on the posterior aspect of the sacrum, going towards the head of the greater trochanter, but all it's doing is causing rotation. It does external rotation of the entire hip. So that one's also going to be out. And same thing with adductor longus. It's basically the opposite. It's on the inside of the hip now, causing a deduction of the pelvis. Again, not going to pull the innominate anteriorly or posteriorly. So just like that, we're able to roll out everything. But let's talk about the rectus femoris. Put proof in the pudding here. Okay, so rectus femoris is coming off of the AIIS, the inferior iliac spine, and coming all the way down anteriorly, inserting into the patella to help you with knee extension. If we were to shorten this muscle from this position, you have one of two options. Either you're going to, depending on what's fixed in place, if the pelvis is fixed in place, you'll just straighten the leg. You'll extend the knee. If the foot is fixed in place, then you can imagine that you're just taking this entire innominate and rotating it anteriorly. So it might look something like this after forceful contraction. And now you can see, granted the leg is a lot smaller here, but you can see that we have shortened the rectus femoris and we've pulled this entire innominate anteriorly, we've rotated it anteriorly. And so that's why the correct answer here is C, rectus femoris. These types of questions, use your puppet hands to figure out the innominate diagnosis. If they ask you about the muscles, then you have to think about your anatomy. Just picture the muscle, where it is, and what would it look like shortened. Then ask yourself, what's moving? Is it the foot that's moving? Or is it the innominate that's moving? Here we have an innominate dysfunction, therefore it has to be the innominate that's moving.